We'll have to work on your new one. Okay, so let's talk about the ligaments of the foot and ankle. And we'll just yeah, go through the ligaments. So looking at ligaments and tendon injuries, there are a number of different types of injuries. This is one classification system back in 1988 where they talked about type 1, 2, and 3. 1, you get thickening, increased signal intensity of the tendon, which we usually call tendinosis. Type 2 becomes thin and narrowed, which I don't really see that often, so I don't use this type system, but you may hear about it. A type 3 would be a complete rupture. So when we talk about the ligaments, let's start with the lateral, then we'll talk about the medial posterior sinus tarsi and the Lisfranc ligaments. There are many other ligaments, and we'll talk about the spring ligament later as well. So the lateral ligaments are the anterior and posterior talofibular ligaments, the anterior posterior tibiofibular ligaments, calcaneal fibular ligament, and calcaneal navicular ligaments are typically the ones described. Looking at the anatomy, here posteriorly, we can see the posterior talofibular ligament, the Fibulo-Calcaneal ligament coming down through here, and then we can see some of the syndesmosal ligaments here and the posterior ligaments of the ankle proper back here. We'll talk about those in a little bit. Anterior tibiofibular, anterior talofibular, Fibulo-Calcaneal ligaments, and then there are ligaments between all the bones. But we're going to talk about the primary ones involved in injuries. And you'll have seen a lot of these. This is a little bit higher up. When we get up close to the dome of the talus, the distal fibula is a D-shaped structure. Anteriorly, we have the anterior tibiofibular ligament, posterior tibiofibular ligament here. If you go up a little higher, you'll get the syndesmotic ligaments in here. But when we get up to the tibia, we're still at the talus here. When we get up more proximally into the tibia, the syndesmotic ligaments will be between the distal tibia and the fibula. We'll talk about those later as well. More inferiorly, where we have the most common injuries, are the anterior talofibular ligament. And if we keep going farther down back here, there's the Fibulo-Calcaneal ligament, which comes off the tip of the fibula and extends posteriorly and inferiorly to attach to the calcaneus. Ligaments. Tears are like every other ligament tear. You tend to get increased signal intensity and thickening. And when it's a grade 3, we have a complete tear through here, which we can see. So that's a typical appearance of kind of a subacute tear of the anterior talofibular ligament. And as you know, generally, if you have an acute tear of the anterior talofibular ligament, because the mechanism is really inversion and plantar flexion, you'll also tend to get a tear of the Fibulo-Calcaneal ligament as well. Here we're a little bit higher up, and here's an anterior tibiofibular ligament tear here. There's the ligament. It's thickened because it's injured, and then we can see where it's been avulsed off the bone over there. So, and here we can, there again, we can see tear of the anterior talofibular ligament. Now, when you get injuries that cause an inversion injury to the talus and calcaneus, which are often called pronation injuries, then you tend to get a distraction tear of the anterior talofibular ligament and the Fibulo-Calcaneal ligaments, and then the talus butts over here against the medial malleolus, and you get these oblique fractures of the medial malleolus, which occur in an oblique manner. So this lets you know that the mechanism of injury is inversion or pronation type injuries. When you have the eversion type injuries, the fracture that you get on the medial ligaments is horizontal because it's a traction injury, whereas this is an impaction injury, and so it pushes the distal tip of the medial malleolus medially, producing this typical oblique fracture. So the plane of the fractures, as well as the location of the ligament injuries, tell you the mechanism of injury, which can be helpful. So with pronation or inversion type injuries, you get these oblique medial malleolar fractures. You can get a lateral impaction injury on the lateral aspect of the talus. You can also, depending upon the exact direction of the force and the severity, get a posterior malleolar fracture. In some classical literature, this is the posterior malleolar fracture means it's a higher force injury, and that may be true, but a lot of it is just the direction of the forces. You can get tears of the sinus tarsi ligaments, and so this is a major cause of sinus tarsi syndrome, where you get instability of the center of the ankle. You can get avulsion injuries off the fibula. So in that particular case, what you would have would be
John,
a fracture of the distal part of the fibula. Yes.
John.
Yes.
Is pronation and inversion the same? I thought that eversion is pronation.
Pronation is basically when you
it's like a flat foot. It's a pronated foot.
Pronation is when you take the lateral aspect of the foot and rotate it down medially. So pronation is really more a motion of the foot. Inversion is really a very similar motion, but it's primarily of the ankle. Eversion is the opposite direction. Eversion kind of lifts up the lateral aspect of the foot, and it's like an eversion injury.
Okay, I just am a little confused on this because I always felt pronation was eversion and not this. So anyway, I'm sorry to interrupt you, John.
Why don't we look it up again? Maybe I'm wrong.
I think that's something we better check out.
Okay, let's check that out, and we can discuss it next time.
Right.
And you can get across avulsion fractures. You can get articular cartilage injuries because of the impaction of the talar dome against the tibial plafond. Antero-lateral impingement can result from this, and you can also get injuries to the common peroneal nerve due to this mechanism, or it's often associated. Okay, and then here we can see an anterior talar fibular ligament tear in this particular case. Here we can see the tear of the soft tissues laterally in this particular patient, and we can see some medial malleolar injury. Medial malleolar injury, not completely fractured. So this would be the impaction injury of the lateral aspect of the medial aspect of the talus, and then this would be an impaction injury of the medial malleolus, and this would be of an inversion type injury. Okay, so this is a patient who had an injury on 1604. We can see the tear of the anterior talofibular ligament. Patient came back 6 months later, and you can see it's now healed. So these heal in with scarring. These often had surgery in the past. In fact, I had surgery on both of my ankles when I was in high school because of these injuries. But now it's quite uncommon to do surgery for an anterior talofibular and Fibulo-Calcaneal ligament tears because it's been shown that these heal in very nicely, and you tend to become stable after it. So it's uncommon for these, but I'll show some examples of surgeries. If they continue to be unstable after repetitive injuries, then still they're occasionally repaired. Okay. What's going on here?
All right, so we have two coronal images of the ankle, and they placed a soft tissue marker along the distal fibula. It looks like this is a adolescent or pediatric patient. Some of the physes are still open, but I do see some edema in the distal fibula, so I'd be concerned about injury of those lateral ligaments. I'm not sure if this is the anterior talofibular ligament.
What do we do see here? We don't see the ligaments here. What do we see?
Marrow edema within the fibula.
What's this? This is a fracture, right?
And that's a little fracture.
Oh, I see.
So this is actually
Unless there's an accessory bone there.
Oh, I see. Okay, so that's not just tendon. There's a fracture at the distal fibula.
Right. I'm not sure. I have to defer to John on this one.
Yeah, so this is a transverse fracture of the distal fibula. In these young kids, go ahead, John. Okay.
No, I'm deferring to you on this. Go ahead.
In young kids, it's the bone that's the weakest, typically the weakest. The soft tissues tend to be very robust, so they tend to get these avulsion fractures. And this is crosswise, so this is an inversion mechanism of injury with a distractive fracture of the lateral malleolus. If this were more severe with a lot more force, then you might get an oblique fracture of the medial side. But this is an avulsion fracture of the fibula due to an inversion mechanism of injury. In an older person, this would have been an anterotalofibular and a Fibulo-Calcaneal ligament tear and not a bony fracture.
If you say that this is a avulsion, then the calcaneus goes into a varus position. In other words, the ankle goes into the varus.
Right.
And not valgus.
Right.
Yeah. Am I correct, John?
Right.
Is this the same set of image, same patient? Because it looks like there's a fracture of the anterior aspect of the distal fibula there.
How's this different?
Here, I see less marrow edema maybe, and I think there's also a tear of the ATFL.
Well, there's the ATFL.
Mm-hmm.
It looks like it probably attaches to the fracture. You see a lot of eburnation here. In this particular case, of hypertrophic bone formation.
This is
avulsion.
Never properly treated.
So here again, we can see an ossific fragment along the anterior aspect of the distal fibula. It looks like an osseous avulsion injury of the anterior talofibular ligament.
Yeah, the X-rays. If you look back at the old X-ray literature, this would be called an os fibulare, and this was thought to be one of the congenital ossicles. But if you look at this carefully, the anterior talofibular ligament attaches to the ossicle, and this was an old avulsion fracture. And in this situation, since the anterior talofibular ligament attaches to the unstable ossicle, this is actually an unstable lesion. So it's not.
It's an avulsion fracture from way back of the distal tip, distal fibula, and that's from childhood.
Yeah, and it shouldn't be considered a normal variant.
okay. We're looking at two axial images here. There's significant thickening and I think it looks like almost metallic artifact in the region of the anterior talofibular ligament. I see maybe some post-surgical changes. Did they correct this? Okay. This is when they did the surgery and they repaired the ATFL.
Yeah, this is chronic scarring. This was post-operative scarring, and this patient continued to have symptoms from impingement from the hypertrophic scar formation after the surgical procedure.
The 37-year-old with right ankle pain 3 years after a fall. It does look like there's thickening of the anterior talofibular ligament, so this is compatible with remote injury.
This is 11/28/09.
Mm-hmm.
This is 12/22/10. So
A year later. Okay. So there is some increased, I guess, scar tissue along the anterior fibular ligament. They repaired it. Okay.
So you can repair it. Most of the ones now.
That looks like a chewing of scar. Are both these the same date?
Well, this is earlier. Patient continued to have chronic pain, so they then operated on it. And this is these are two cuts of the same patient.
I see.
And that's the postoperative scarring. Here's another patient who had surgery.
History of surgery for lateral ankle instability, treated with Brostrom procedure and ligament augment repair. And you kind of, you see the, I think you see a surgical anchor at the talus, and I don't really see any good ligament there. Maybe there's some, I think it's maybe retorn. See some scar tissue there, and actually a lot of, it looks like there's a lot of, is this reaction to the surgery? So a lot of soft tissue reaction.
This procedure is not used anymore,
Okay.
as far as I know. The fixation is now done with a not an anchor, but a screw and a washer into the calcaneus.
Okay. All right.
All right. 21-year-old with an injury while working out, rule out stress fracture, and they placed soft tissue markers along the medial and lateral malleoli, and there is some fluid and edema along the lateral ankle. I don't see the ligaments very well on this slice, and then there's also edema along the medial malleolus, so I think this could be an inversion injury with a contusion. And here on the axial images, we see increased signal and irregularity at the fibular attachment, so I think this could be a tear of the ATFL at the fibular attachment, probably at least grade 2 tear.
So this is on 7/24/2012. Here's on 2/21/2013.
So she continues to have pain here along the medial malleolus, and there's still edema. This would make me concerned about an injury of the deltoid ligament, or not sure if there's a ununited ossific fragment along the medial malleolus. I didn't see one, but.
So they still had pain,
Mm-hmm.
and then they had surgery.
Okay. Okay, so here it looks like there's hardware in the lateral talus, so they may have repaired the lateral ankle ligaments, and that edema in the medial malleolus has improved.
Yeah, this is 2013, and that's old stuff now. They don't. This procedure is no longer used, as far as I know. But anyway, I'm interrupting your lecture here, John. I
guess there's.
don't mean to.
I guess we're also seeing some decreased T1 marrow signal intensity surrounding the hardware and associated edema. So if they're concerned, this may be seen with osteomyelitis.
Yeah, this was more edema than you would expect just from surgery, and it persisted for a while. And this was an infected site.
That's the first thing you think of. You're absolutely right. C-reactive protein and SED rate and IV antibiotics after a culture.
This is all much
Now looking at the posterior talofibular ligament there, we can see, I think this is an osseous avulsion. Looks chronic to me.
Yeah, I don't see too many posterior talofibular ligament injuries, but this was an old avulsion back here, as you can see.
We don't have an age here, but what age do you think this patient is?
This one or this one? This one?
Yeah.
Younger.
Would it be somebody younger or older?
I would think it would be someone younger, since the bone is it seems like the soft tissue is stronger than the bone.
Yeah, probably, but we really can't tell in the posterior aspect.
Right.
I don't think
The patient,
at this level.
the patient was primarily symptomatic, actually, because of the posterior tibialis tendinopathy.
Yeah, that's what I was thinking.
So this was a kind of an ancillary finding. It was probably old.
All right, so here they put a soft tissue marker along the antero-lateral ankle, and there's fluid signal intensity in the expected region of the ATFL and the PTFL. So I'm concerned about complete tears of the ATFL and PTFL. I'd also want to evaluate the syndesmosis, and there's an ossific fragment along the posterior talus. May also have a posterior fracture. Oh, os trigonum. And that's interesting.
So
The thing about these injuries, you have to remember there's rotational component to every one of them.
Yep.
And so you have to be a little careful about what you say in terms of injury. But always think that there's more trauma than you see on one or two cuts. Right, John?
Right. So let's go on to the Fibulo-Calcaneal ligament. It can be seen in all the planes, but in the coronal plane, it comes off the distal tip of the fibula, comes down deep to the peroneal tendons, and then posteriorly and inferiorly to where it attaches to the calcaneus here on the lateral side. That's the coronal. On the axial images, we can see it coming off the distal fibula deep to the peroneal tendons and then attaching to the lateral aspect of the calcaneus. Here's a normal appearing one. Here's a torn fibulo-calcaneal ligament. And here's also a tear of the fibulo-calcaneal ligament. We can see thickening with increased signal, and it should be a black structure on the PD fat-sat images, and here it's markedly thickened with increased signal, and this was an acutely torn fibulo-calcaneal ligament. And this is what it looked like on the T1 weighted images, thickened, abnormal signal intensity, all the way up to where it should be attaching to the distal fibula. Okay.
So this is on March 7, 2006. I'm guessing we're at the level of the calcaneofibular ligament, and I don't really see a good ligament there. It looks pretty.
Okay, so this is 3706. This is 6.5 months later.
It looks like it's well, it looks like we have a normal fibular, well, a little bit thickened actually, fibulo-calcaneal ligament. So
we see these ligaments, and if they're a little bit thickened, we say compatible with an old injury. And this is the reason why we say that, is it's a typical way that they heal with scarring.
6 months is still not completely mature. It takes a good year to do that.
All right, so here it looks like we may be a little bit higher up near the level of the syndesmosis, and on this image I don't see the anterior tibiofibular ligament very well. There's fluid extending along the syndesmotic interval. Uh-huh.
Studies have typically shown that the best finding on MR of syndesmotic ligament injuries is fluid here between the distal tibia and fibula. It's hard to see the individual ligaments, and you also look for tears of the anterior and posterior tibiofibular ligaments as well. And this is typically what's called a high ankle sprain. And in sports, it's important because it lets the player and coaches and trainers know that it's going to take another 4 to 6 weeks before they're going to be able to go back into athletic activity, and that's kind of pushing it. Often with these, you'll also see some edema in the distal tibia here.
Trainers love that word high sprain and low sprain, and the coaches hate the high sprain.
Yeah, right.
For a good reason. So you gotta be a little careful when you use high and low. In this situation, high is bad.
Yeah, yeah. Now,
in basketball, high is good.
If you look in a lot of the literature, it's what they'll say is that with lateral ankle injuries, first you'll tear the anterior talar fibula and the Fibulo-Calcaneal ligament, and then you'll tear the more superior ligaments. That's definitely but not been my experience. My experience is that there are two different mechanisms of injuries, and you can often tear the tibiofibular ligaments and not tear the talofibular ligaments. John?
That's true. I agree with you, John.
This is a case where the tibiofibular ligaments were torn, but the talofibular ligaments were still intact.
Yep.
It may not be completely normal, but it's still mechanically intact.
Yeah. It's not always the case, but most of the time it's either high or low.
And my guess, though I don't know of any data to prove it, is that you probably have a little bit better prognosis when the anterior talofibular ligament is still intact. But I don't know data to prove that.
That I'm not sure of, because a lot of times the high winds up with surgery, and then the low is also torn.
Yeah.
So it depends on the amount of force that occurs in that injury.
Yeah. And this is an inversion injury. As we talked about earlier, it's also called a pronation injury, and you typically have internal rotation associated with the high ankle sprains. Okay.
Is that of the ankle?
Yes. Yes.
High ankle sprain. Yeah. I'm not sure how they use that terminology.
Well, most of the people I work with use it beating the anterior syndesmotic and the anterior and posterior tibiofibular ligaments, as opposed to a low ankle sprain, which is the talofibular ligaments and the Fibulo-Calcaneal ligaments.
Inversion tears the lateral side and causes fractures of the medial malleolus. Eversion avulses the medial malleolus and fractures the fibula. But anyway, I think there's a little bit of a confusion in terminology.
Okay. Here we're looking at the lateral ankle. I think there's skin markers on the medial side, though. So here, I mean, I think we're at the level of is this the tibio-talar ligaments? Are we too high up here?
What's the main issue here?
looks like, yeah, it looks like there is a tendon there with,
Yeah, why do you think it's in the fibula?
yeah, it's the peroneus brevis. Yeah,
Right. That's an operative procedure.
yeah. Jones procedure.
Yeah, they don't use that anymore. Basically, what that is, you want to go into the treatment, John, or now or not?
Go for it. Go for it.
You drill a hole in the fibula. You cut the peroneus brevis at the muscle area or just below it, and attach it to the longus, and then use the brevis from the distal part and drill, weave it through the hole in the fibula, and and attach it there. In other words, replacing the anterofibular ligament.
Good. Thank you. And that helps.
That's for instability.
Right.
But what they do now is they drill the hole and do the same thing as the Jones procedure, but you weave it through the hole from superior aspect down to the calcaneus and weave it around a screw and a washer that has, the washer has teeth in it, and it attaches it to the calcaneus, and then you bring the other part of the tendon that's left and reattach it to the tendon above where the fibula is entered by the tendon. So you have the first part of the tendon going through the hole goes underneath the peroneal tendons, and the second it goes over the top of them, and that makes a very nice ligament replacement. But you need to see a picture to be able to really understand it, I think.
All right, so this is a dorsiflexion weakness after severe inversion injury playing rugby, and there's some edema in the peroneus longus muscle in the anterior compartment. And here higher up, we can see edema in that anterior compartment. I'd be concerned about an injury of the peroneal nerve.
That's a common injury that's associated with inversion injuries of the ankle, but it's one that then leaves with foot drop. Yeah. Okay.
Is there the diastasis there, John?
Oh, what?
Diastasis, in other words, separation of the two bones.
I don't think so here.
Down below that first.
I mean, there might have been down at the time of the injury below.
Yeah, okay. Because that looks wider than usual.
Yeah, at this level, I'm not sure. Okay, why don't we wait and go over the medial ligaments tomorrow? Okay, good stopping point. Thanks.
Thank you.
Sounds good. Have a good one.